For question 2, the correct answer was B, Mallory-Weiss tear brought on by severe vomiting, which you would expect to see a clot adhering to a mucosal tear at the GE junction. For question 3, the correct answer is D, H. pylori stool antigen testing. Urease breath testing would be another valid option, but was not offered as a choice. Hydrogen breath testing, the option presented here, is done to diagnose small intestine bacterial overgrowth syndrome. For question 4, the correct answer is C, gastrinoma, in the setting of Zollinger-Ellison syndrome, which can co-occur with Cushing's syndrome. The clue here is that she has a negative H. pylori testing and her ulcers are refractory to PPIs. Let's move on to small bowel or colonic bleeding, and lower GI bleeding. There are many potential causes. Painless bright red blood per rectum is most commonly caused by diverticulosis, which is overall the most common cause of lower GI bleeding. Vascular causes can include small or large bowel AVMs. Hemorrhoids can also cause bleeding and can be painful or painless, depending on if they are external or internal hemorrhoids, respectively. Bowel ischemia can also cause lower GI bleeding and typically also presents with significant abdominal pain and cramping. Inflammatory bowel diseases and some GI infections can both cause bloody diarrhea. Malignancies can cause bloody or dark stools and are extremely important to rule out or catch early when investigating a GI bleed. Lower GI bleeding can also be iatrogenic in the setting of recent abdominal surgeries or colonoscopy, especially if polypectomy was performed. Initial triage, resuscitation, and management of a lower GI bleed are very similar to an upper GI bleed to ensure patients are stable, have good IV access, anticoagulation is reversed if possible, and they are ready for transfusion if needed. PPI should also be started as an upper GI bleed can present with bloody stools in around 15% of cases. Colonoscopy is the gold standard not just for diagnosis but also management, as depending on the cause of the bleeding, it can be stopped with cautery, coagulation therapy, or clipping. Bowel prep prior to colonoscopy is vital or else you won't be able to see or do anything. In a non-urgent setting, around 8 to 10 hours are needed to complete bowel preparation and evacuate the colon. But for severe bleeds, when you may not be able to wait that long, you can decrease that time by placing a nasogastric tube and using it to more aggressively push prep solutions. If the patient is unstable and has brisk bleed that can't be found on colonoscopy or endoscopy, you may need to consult interventional radiology for angiography and embolization of blood vessels, especially if the bleeding is likely coming from the small bowel, which may not be easily accessible with endoscopy. CT angiography, or tagged red blood cell scans, can also be helpful to localize the source of bleeding. Video capsule endoscopy can also be performed, but this takes time as the video capsule must pass through the GI tract and then be retrieved and the video reviewed. Ischemic colitis is an uncommon cause of lower GI bleeding, but it is always an emergency. It can be caused by anything that reduces or stops blood flow to the GI tract, like thrombosis or occlusion of the mesenteric arteries. It can also be caused by systemic hypotension, especially in the area of the splenic flexure of the large intestine, which is a watershed area, meaning that it is a junction of two arterial territories and therefore vulnerable during episodes of hypotension. Other causes can include vasculitis caused by radiation or other systemic large or medium vessel vasculitides. Symptoms and signs of ischemic colitis are crampy abdominal pain, tenderness out of proportion to the pressure used for palpation, abdominal distension, bloody stools, elevated lactate, and often a leukocytosis. This can progress to lactic acidosis and multisystem organ failure. It is typically diagnosed with an abdominal CT scan with IV contrast or abdominal angiography. Patients with ischemic colitis should undergo aggressive volume repletion and have an urgent surgical consult for evaluation, as this can be a surgical emergency. Revascularization by interventional radiology with stenting or thrombectomy may also be needed. If there is an underlying cause like a hypercoagulable disorder or a vasculitis, that will also need to be addressed. Let's try some questions.